Good afternoon, ladies and gentlemen. Welcome to the 10th Complex PCI 2025. I'm BK Gu from Seoul National University Hospital, and it's my great honor and pleasure to moderate this session with the Professor Yoshinobu Murasato from Japan. So I would like to also introduce the panel. Please come up to the podium. Dr. Abdullah, Dr. Chui, Dr. Khialani, Dr. Lee, Dr. Park, and Dr. Suesat. So as you are a little bit behind the schedule, so let's start with introducing the first speaker. So Professor Hyeon Kim from Asan Medical Center will talk about the concept versus technique in bifurcation PCI. Dr. Kim, please.
Yeah, thanks for the introduction. So recent major trials, including ischemia, have consistently demonstrated that in stable heart disease, invasive strategies do not necessarily provide survival benefit. So it all comes down to how much ischemic burden we can actually relieve. So when we look at side branches, their contribution to myocardium is often quite small. And usually it is less than 10%, except for a few branches. So therefore, ischemic burden is mainly relieved by main branches stenting. For small side branches, we are told do not touch. So in this case, after pre-dilating the main branch, the angiogram made me pause and reconsider whether leaving the side branch untouched means do nothing. So I chose to pre-dilate the side branch and as well, followed by crossover stenting. So for true bifurcation, the provisional stent strategy remains the recommended starting point. But we must admit, not every provisional stenting goes as smoothly as the textbook suggests. So jailed wire protection is the simplest and most commonly used method to prevent acute occlusion. In most of these situations, the jailing is common and asymptomatic, which are rarely ischemic. Data tells us that FFR measurement in jailed side branch is both safe and feasible, and in most cases, FFR confirms no functional significance. So follow-up data showed that no significant decline, and in lesions treated with kissing balloon inflation, the acute functional gain was maintained over time. So most asymptomatic jailed side branch with TIMIS reflow do not need further treatment. But what about the total occlusion? So across multiple studies, side branches occlusion occurs in about 10% of cases. And sometimes this is not benign, and we have shown that more than half of the case peri-procedure MI was associated with side branch occlusion. And importantly, outcome diverged depending on whether peri-procedure MI or not. So even when acute occlusion is anticipated, it is not something we can always prevent. And I did a pre-dilation at the side branch ostium, but look what happened. And so we often use microcatheters or dual lumen catheters or even CTO wires, and sometimes rewiring takes time and maybe more than half an hour. And fortunately, the flow was restored, but the rescue procedures are not always successful. And issues like false lumen or rewiring failure can lead to a significant peri-procedure MI. So how clinically relevant this side branch occlusion? And using the data from large registry, side branch occlusion was significantly associated with worse clinical outcomes. And even in untreated side branch occlusion has been linked to significantly worse prognosis. So many factors have been suggested, and this study shows that the nature of plaque, specifically calcified or low attenuation plaque, contribute more to occlusion than a simple plaque burden. So actually, the most certain way to protect the side branch is upfront two stent. So for most bifurcation, one stent or two stent showed similar clinical outcomes. However, in complex bifurcation disease, like definition 2, the two-stent strategy reduced the target lesion failure. So what about the left main bifurcation? And the cell complex is usually large and supplies a significant myocardium. So therefore, preserving the cell complex is critical. And this is where we often debate between one stent versus two stent. So in situations, IVUS guidance becomes mandatory. And my question was, can IVUS could identify the distal left main better suited for two-stent approach? So all these shows angiographic gelling of the cell complex ostium. However, all showed a negative FFR. So our previous study shown that the single stent crossover rarely resulted in functional compromise. So building on this, our new focus was on what predicts cell complex compromise and aiming to identify pre-procedure IVUS variables that can guide decisions between one stent versus two stent. So among 141 patients, 24 showed a cell complex compromise and minimal lumen area less than 3.8 and plaque burden more than 57 emerged as a predictor of cell complex compromise. So again, the most reliable way to protect cell complex is to use an upfront two-stent with careful IVUS guidance, ensuring that adequate finer MSA is essential. And you can refer to our recently published MSA criteria in either two-stent or one-stent. So in summary, it is the main branch that determines the ischemic relief and the long-term outcomes. And the cell complex is unique and deserves IVUS-guided decision-making. And whether we choose one stent or two stent, the key is to finish the procedure without a side branch compromise. Thank you.
The next speaker is OCT-guided bifurcation PCI, how to select ideal stem cell from Dr. Takashi Akasaka from Japan.
Thank you, Dr. Murasato and Professor Koo. It is my great honor and pleasure to be here again. Right, and this is my disclosure. And as you know very well, this is an October trial published 2023. They divided 1,200 patient OCT guide and angio guide 1:1. And this is a result, as you know also very well. There are no significant difference in each endpoint, but composite endpoints, they identified OCT guide is superior than angio guide. However, this is an OCT, the protocol paper of an October trial. They recommended how to do the optimal rewiring through a stent stud, as shown in this slide. They only describe, exclude the proximal rewiring, and the wire should be distal close to the carina by a longitudinal view, as shown in this slide. But it might be very difficult to understand, right? And this is a representative 3D OCT image of LCX orifice restenosis after left main bifurcation stenting. You can identify the restenosis by a neo-intimal proliferation at the bifurcation with 3 LCX different orifice if you leave it alone without any dilatation of the orifice. Sometimes you can see these findings during follow-up, right? And why this will happen? Because if you select the distal cell, it's a longitudinal schema, right? And you can easily treat the carina. But if you select the proximal cell, you leave the metal carina here, even if you do the kissing balloon technique. This might demonstrate the lower shear stress and may accelerate the proliferation of the neo-intima. And the right-hand side demonstrates the type of jailed strut and the flow area and the possibility of the flow disturbance and make the proliferation of the intima at the carina as shown in this slide. So complex jailed type makes flow disturbance much more and may make a problem during long-term follow-up. And as you know, in bifurcation, there is a vessel size change in main vessel at proximal and distal side branch. And if you select the stent, just proximal reference, stent distal edge, dissection and carina shift may occur as shown in the left-hand side schema, right? And if stent select adjust distal reference, no edge dissection and no carina shift may happen. However, stent incomplete apposition may occur, and also therefore the pod is recommended to obtain a good result as shown in this slide. After pod, it's quite easy to select the side branch by rewiring. This is a longitudinal image of the left main bifurcation after pod. After pod, it's quite easy to select the distal cell. This is about longitudinal concept, right? After a kissing balloon, after rewiring, the stent strut at the carina at the side branch orifice move to the proximal side opposite to the carina side. This is an ideal result. It's quite easy to understand, but we have to also think about the end-face image. This is an open carpet view. You know the carina, there are yes, different type of the link, right? This is peak to valley, and this is peak to peak. And here is a different type of the link position. If there are link at the orifice, this is no link free type, and if this is the link is at the center of the orifice, this is a link connecting type. So it depends on the wire position demonstrated by the different color, distal cell selection and proximal cell selection, right? And Dr. Onuma previously recommended how to select the distal cell as shown in this slide. This is a peak-to-peak stent design, and the bottom is a peak-to-valley design. If you succeed to select this portion, the result might be very good, right? And these data is based on the Dr. Okamura's pilot study using 3D OCT image at the bifurcation piece, bifurcation region. The upper side, you succeed the distal cell, and then after KBT, you can get a good side branch orifice. The bottom is the same. However, if there are link at the orifice, even if you succeed the distal cell, you still some strut at the orifice, and also the main vessel cell condition disturbance can be identified. This is a worst result because we have to focusing on the main vessel compared with the side branch. And if you avoid this, you try to select the proximal cell. However, if you even if you do the kissing balloon, you still have a metal at the carina. This may cause the intimal proliferation and restenosis at the orifice. And this is the result. Finally, the link-free and link-connecting is nearly one-to-one. However, after POT and KBT, they succeed to get an optimal result, also and suboptimal result, one-to-one, as shown in this slide. And in a case with a suboptimal result of the side branch ostium, incomplete stent apposition is significantly higher than the optimal result. And the instant restenosis is numerically high, but statistically no significant difference because of the lower number of the patient. Then we did the 3D OCT guided bifurcation registry, and 600 patient divided OCT guide 400 and non-side branch opening 200, and we get on 3 years follow-up, and we are now analyzing, organized by Dr. Junya Shite. And this is the result. Final optimal result is 65%, and suboptimal is 35% result. Recently developed 3D OCT demonstrate a clear image of 3D demonstration of the stent strut and wire position, as shown in this slide. And we can identify easily the incomplete apposition by the color as shown in this slide. And then this is one of the examples. We try to put a stent just proximal to the bifurcation. However, the stent start cross over the bifurcation, and incomplete apposition can be seen. Now, after port, you can identify the good side branch opening in the distal part, carina site, and then blind manner, we can easily select the distal cell, and after KBT, you can obtain a good result as shown in this slide. This is another case. This is an angio, and initially the wire is in the proximal cell. Then try to use the dual lumen catheter as shown in the right-hand side, and then try to push in the wire through the side hole. And then if you push in everything in the side branch, if it is possible to push in, you miss to select the different cell, right? And then if you succeed, it might be difficult to push in, you succeed to select the different cell as shown in this slide, and then succeed, you can confirm the wire in the distal cell when you pull back the original wire and the catheter, and then after KBT you can obtain a good result as shown in this slide. This is a summary of 3D OCT imaging for bifurcation PCI using dual lumen catheter as shown in this slide. I already explained you. Right, but the DK crush, it might be much more complex. We try to select the mid portion, but sometimes difficult to predict the final result. But using 3D construction, you can confirm the final result as shown in this slide. Right. And this is my conclusion today. OCT may provide us important information, including side branch wire position, stent strut, link, and cell condition at the side branch orifice three-dimensionally, and allow us to perform ideal cell selection by side branch rewiring for effective KBT. For side branch rewiring, dual lumen catheter using the original wire at the inappropriate cell should be very useful for detecting ideal cell under the 3D OCT guidance. KBT under the ideal cell selection at the side branch orifice using 3D dimensional OCT guidance after port may result in the most appropriate bifurcation stenting and improve the prognosis of bifurcation stenting, although there are still some limitation in case with link connecting type of cell condition at the side branch orifice. Thank you very much for your kind attention.
Okay, thank you, Professor Akasaka, for the elegant presentation. So we're going to have a discussion after 3 talks. Next speaker will be Professor Rohit Mody from India, and he's going to talk about the left main provisional versus 2-stent strategy. Dr. Mody, please.
Yeah, thank you very much. Good afternoon, everybody. I'll be talking about provisional versus 2-stent strategy in left main bifurcation PCI. No potential conflicts of interest. So how should I plan a distal left main bifurcation, the provisional or elective stenting? The important is main vessel stenting and optimization techniques and side branch evaluation and treatment. So the best intervention is the one that avoids the unnecessary. The 16th European Club Bifurcation Consensus describes provisional stenting as a default approach for most bifurcation. The ideal indication can be optimal side branch less than 10 millimeter. And a good preparation writes the script for a flawless procedure. We must carefully plan our wiring, lean preparation, and stent and its optimization. So this is the provisional stenting strategies. Out of these, the kissing balloon pot is the most popular technique found to be most useful. This is a simple word regarding how to place our pot balloon, just the distal tip at the carina. Again, the pot balloon, it is shown that after a pot with compliant balloon of 4 millimeter at 16 atmosphere, a complete correction of malapposition with restored circularity is achieved. So we must look for the common pitfalls, the pot-related issues like incomplete pot, excessive pot in left main, or wrong final pot. Every complication whispers a warning. Listen early and act early. So the final takeaway are, in bifurcations, PCI, precision is the power. So I will describe a case, a 54 years case presented with angina and STMI, diagnosed 3 days back. You can see there is a left main disease with a triple vessel disease. You can see the IVUS findings. There is a previously put stent with an ISR in the proximal LAD and tight left main. It's stented. The role of the IVUS, I wanted to see, if you want to see the side branch compromise, there can be an eyebrow sign which can be present in 46% of our patients. Similarly, when we do the pot and the final kissing balloon, you must look for the stent deformation. In this case, the stent deformation was corrected with a good pot done, and you can see a very nice final result. Another techniques are decay culotte. So in that, the pot, distal rewiring, kissing balloon, and pot, every rewiring defines the outcome. Decay culotte simply magnifies it. Again, a patient of 80 years old where we did this is a calcified left main disease, tight left circumflex portion, first rotablated in the left circumflex, then in the LAD, and finally from distal LAD till the proximal LAD, and then the stent from LCX to left main, and through the struts, the LAD stent, post dilatation, 2 pots and 2 kissings, and this is the final pot, and the final result, you can see a very well expanded carina in the stent boost and a good final angiographic result. There can be inverted decay culotte chosen when initial side branch wiring expected to be difficult. Inverted strategies are solution for anatomy, not for complication. Now the 2-stent strategy, decay crush, it rewards discipline. It punishes shortcuts. There are many pitfalls and troubleshootings. I'll go into detail later on. The technique, so the technique should be mastered. Training is essential. The final message is respect anatomy, respect pot, respect rewiring rules, and master kissing balloon. The technique is knowledge, mastery is repetition. So these are the 9 steps of decay crush. All are important to get a good results out of it. But there can be many pitfalls. There can be incomplete side branch stent deposition. There can be unpredictable balloon position for the side branch stent crush. There can be unpredictable direction of the side branch stent crush. Then there can be incomplete side branch stent crush with balloon, and there can be high possibility of unfavorable side branch rewiring position. So there can be incomplete side branch crush during the advancement of the side branch balloon, mostly in complex morphology. So there can be incomplete lean coverage and insufficiently crushed stent with the decay crush. So to my message is to do intravascular imaging guidance is mandatory at every step of the procedure. So the fundamental difference between provisional and upfront side branch stenting, you can see in tap and culotte we get 2 layers proximally in the main vessel. In the decay crush we get 3 layers of the stent. This is the basic. But the guideline 2018 ESC guidelines, they still give class 1 indication to the provisional stent in the main vessel. But the DK Crush 5 trial showed better results, but to which patients does it really apply? The patients with the ostial LCX disease extending more than 16 millimeter. So the recent meta-analysis showed that the DK Crush provides best outcomes. This is the provisional strategy as the reference treatment. Then the recent meta-analysis showed that the DK Crush provides the best outcomes. Pooling all the bifurcation RCTs in a network results not applying to majority of the bifurcations. Similarly, if we see in if we divide these depending upon the side branch length, if the side branch length is more than 10 millimeter, that it favors DK Crush. Otherwise, the results the results of 1 stent and 2 stent strategy are the same. So this is the just words about tapping. Then the intracoronary imaging is important, as I told you. So let's see some myths. 2 stent strategy is worse outcome. This is an historical perspective, which was Nordic BBC 1 trials. But at that time, the stents were first generation tests, and 2 stent techniques, culotte crush and T stenting were used. Then the DK Crush came with the provisional stenting, DK Crush 5, which showed the DK Crush to be better than provisional stenting in carefully selected patients. So another myth is all the 2 stent techniques have similar outcomes. In DK Crush 3, you can see the DK Crush was better than culotte trial. So not all the stent techniques are created equal. So now there is a progress in 2 stent crush techniques also, from classical crush to now we are doing DK nano. So for simple or complex bifurcations, we see the size of the severity, lesion length and characteristics, and the bifurcation length and take our decision. We should look for the definition criteria where DK Crush will be better. So these are the steps. You can see the nano crush, just a small protrusion and a crush and a full ostial coverage, computational flow dynamics, minimal flow disturbances. So these are the other 2 stent strategies. So when anatomy challenges you, technique protects you. The best operator choose techniques, but not out of habit, but out of wisdom. If there are 2 bifurcations and large side branch and high plaque burden and need an optimal predictable side branch patency, this crush technique can be chosen. To summarize, the crush techniques have evolved dramatically in 20 years. DK Crush provides the most robust evidence, especially in left main coronary artery. Final kissing balloon is mandatory for crush success. Imaging guidance enhances precision. Provisional remains first line, but crush strategies are superior for true bifurcations. In the art of PCI, bifurcation tests our skill. Crush techniques define it. Thank you very much.
Okay, thank you, Dr. Mody. So we have around 5 minutes for discussion. So any questions, comments from the panels and also from the podium? Yes, please, Dr. Lee.
I would like to talk to Dr. Akasaka. Okay, thank you. It was very impressive that the restenosis was conformed with the 3D OCT in the floating strut part of the side branch opening you showed us. And is this very rare, or come on, it happens often? And I don't understand why the outcome of the 1 stent crossover technique is pretty good in that terms of view. And the 3D OCT image often shows that unreliable results previously, and I wonder if it's reliable now with the updated technology to use as a guidance.
Thank you very much. It's a wonderful question. I think we are not totally follow up every cases, right? But in case with some symptom, if we identify the LCX orifice stenosis, right? At that time, we do the image. We sometimes identify such a side branch orifice tissue proliferation. If we leave it any side branch treatment at the initial PCI, that is the main cause of the stenosis of the side branch orifice. Therefore, if possible, we try to treat the side branch orifice at the initial PCI if we can expect a good result. It might be very important at the moment, I think. And initially, Bifurcation Region Club recommend distal cell selection. It's quite easy to understand conceptually longitudinal image. However, if you try to see the open carpet view in face view, right? There are very complex strand and cell distribution. At that time, how to select the ideal cell is very important. If you miss the inappropriate cell selection and do the kissing balloon, sometimes still there are lots of metal at the side branch orifice. In addition to the disturbance of the main vessel cell condition, it is the worst result, right? The bifurcation lesion treatment, we have to focusing on the main vessel mainly, right? And if we have, we will be able to treat the side branch, we try to approach the side branch. That might be the ideal approach to the bifurcation treatment, I think.
Yeah, I agree with your idea, and wiring near to the carina would be important issue. But in the past, it was very hard to approach like that. But nowadays, we have a supercross microcatheter, which has a preformed angle microcatheter. That could be very helpful in this era, I think.
Yeah. My blind technique, we can select this ideal cell selection up to 40 to 50%, I think. But if we miss the distal cell ideal cell selection, try to do the dual sensor catheter, as I recommend today, right? It is one of the way to select the ideal cell selection up to the 80%, I think 80 to 85%. Success rate.
Thank you.
Okay, so thank you. But for the sake of time, we have to move on to the second part of this session. But we're going to have a further discussion on the above topics as well at the final discussion time. So next speaker will be Dr. Fahim Jafary from Singapore, and he's going to talk about the optimization bifurcation PCI. Dr. Jafary, please.
Thank you, Mr. Chairman, and thank you for the invitation for this talk. I don't have any conflicts of interest related to this subject. When we talk about needing two stents in a bifurcation, there are some unequivocal situations where it is needed, and those are when you have a sizable branch that goes down and stays down, like Dr. Kim showed earlier. And then when you have a sizable branch that would be very, very difficult to rescue because wiring it was very, very difficult. For example, a situation like this where you have a retroflexed side branch that is sizable. In this particular situation, you unequivocally need to stent it because if you have to rescue it, you're not going to be able to. Now, for the remaining situations, the need for two stents depends on what I call B3. In other words, how big is the side branch, how bad is the side branch, and how bold are you? In other words, how do you feel if it was to go down and you were to lose it? So the question you have to always ask is, can we predict whether the side branch will go down? And as Dr. Mody just showed a lot of this earlier, I'm going to reiterate some of the stuff, that there are a bunch of predictors which tell you whether the side branch may actually go down. There are angiographic predictors, there are imaging predictors, and then there are some bifurcation risk scores that have been put together based on these risk factors. So angiographic predictors starts with the bifurcation angle. When you have a narrow angle like you see below, the risk of a carina shift and compromise is quite high. It turns out that when you have a wide angle also, you tend to have a higher risk of branch occlusion, largely because these are sort of difficult to rewire. And so you have sort of a U-shaped relationship between the bifurcation angle and the risk of the branch going down. And so it's important to keep this in mind when you're doing your PCI. When you talk about angiographic predictors, you also look at the side branch disease. And obviously, when you have a side branch that is very diseased up top versus something that is less diseased, obviously the more diseased the side branch, the more likely it's going to go down. And in similar light, when you have a side branch which has disease at the ostium compared to downstream, the more likely it is going to go down when you put in a stent in the main vessel. Also, it's important to consider the size of the side branch, particularly in relation to the main vessel. And when you have a relatively smaller side branch compared to the main vessel, when you put a stent in the main vessel, there's a higher chance of this branch not tolerating any carina shift or plaque shift. And so that sort of roughly speaking, the main branch to side branch ratio, when it's more than 2, that is a predictor of the side branch going down. A bigger side branch is less likely to go down versus a smaller side branch. It's also important to look at the plaque distribution. In other words, which side is the plaque on? And when you have plaque that is on the same side as the side branch, you're more likely to snowplow this plaque into the side branch and lose it compared to when it's on the opposite side. But also what the burden of plaque is in what is called the bifurcation core. And so this is the bifurcation core, which is the central area, both after the bifurcation and proximal to the side branch. And when you have a lot of plaque in the core, in other words, a plaque burden that's 70–80%, you have a higher chance of snow plowing that plaque and putting it into the side branch. And so that also factors into your prediction. They are, of course, imaging predictors, as we saw earlier with one of the earlier talks, that when you have side branch plaque, even when the angiographic stenosis may not be so bad, but when you have heavy plaque in the side branch, it is more likely that you're going to lose this one compared to when you have a low plaque burden in the side branch. And also the so-called spiky carina that was alluded to in one of the previous talks, where when you have the carina that penetrates deep into the ostium of the side branch, it is, as you can think about it, it is more likely that this carina will shift and occlude the side branch. And so a spiky carina is one of the predictors of side branch loss. As you can see over here, a spiky carina, you put a stent in the main branch and you sort of occlude the side branch. There are other similar predictors on imaging, looking at OCT, the carina tip angle, the branch point to carina tip length. All of these contribute to the equation in your mind that are you going to lose the side branch. And a lot of investigators have put these sort of these predictors together in sort of bifurcation risk scores, looking at the resolve score, which looks at plaque distribution, TIMI flow in the side branch, pre-procedure diameter stenosis, bifurcation angle, diameter ratio, and diameter stenosis. And essentially, the more of these you have, the more likely your side branch is going to go down. There is also a V-resolve score, but the one that's sort of most commonly used and most well-known is the definition score that was also alluded to in one of the previous talks, where you look at the side branch disease length, if it's more than 10 millimeters, and then if the side branch is severely diseased, more than 70% for the left main and more than 90% for non-left main bifurcation, along with other stuff. And that other stuff includes calcification, multiple lesions, bifurcation angle, thrombus, and so on and so forth. And when you have one of these major criteria and two of the minor criteria, the likelihood that the side branch will go down is higher, and the likelihood that 2 stents will be needed is also higher. Is there any outcomes data looking at all this? And you've sort of seen some of this. These are all of the trials that have been published so far on non-left main and left main. And I just draw your attention to this recently published meta-analysis, which basically looked at 24 randomized trials, close to 7,000 patients. And the bottom line was that for majority, provisional is as good as 2 stent. However, when you look at when you do a sensitivity analysis and you look at the true bifurcations, the one that were 1-1-1 or 0-1-1, it turns out that in that sort of cohort, a 2 stent approach is better in terms of clinical outcomes. Furthermore, that is driven by the length of the side branch stenosis in a meta-regression analysis. The longer the side branch stenosis in a true bifurcation, the more you benefit from a 2-stent strategy. And this is another meta-analysis which basically again showed similar things, that the provisional approach is okay for most. However, when you look at the purely, true bifurcation cohort, a 2-stent approach, especially DK crush, is superior to provisional. And this is data from Dr. Chen's group, again showing the same thing, that a 2-stent approach is better for true bifurcation. So when should we use 2 stents? Well, there are algorithms which I'm not going to go over because you've seen this before. But basically, again, I go back to B3. How big, bad, and bold. So if you have a large side branch, if you have severe osteal disease in a big side branch, if you have moderate osteal disease but long disease in the side branch, if you have heavy osteal plaque burden on IVUS or imaging, or if that side branch is very difficult to wire and rescuing it would be a nightmare, and when the patient is low bleeding risk, I think a 2-stent approach is going up front is a good idea. There are some gray zones. If the operator is not skilled enough to do a good 2-stent approach, then better not to do it. There is an expansion issue, and this is very, very important, that if your side branch, you cannot expand it, particularly the circumflex, it's very calcified, you couldn't ablate, didn't do a good job, don't stent it. And keep in mind that DK Crush 5 excluded patients who underwent atherectomy. I repeat that, excluded patients who underwent atherectomy. And so when you're not able to atherectomize or expand a side branch, don't stent it. And stability, of course, in a very unstable patient, 2-stent strategy can be both a blessing because you don't lose the side branch, but can also increase complexity. There's also an evolving concept, which is DCB angioplasty for the side branch, which I'm not going to allude to. So final thoughts. While 1 stent is good enough for most bifurcations, a 2-stent strategy will be needed for some cases, and you've got to keep that in mind. And I think all operators should familiarize themselves with at least one 2-stent technique. I don't care whether it's DK Crush or Coulot or whatever, just familiarize yourself with one technique and practice it, because when you do it repeatedly, you will get mastery over it. Ladies and gentlemen, thank you very much.
Next speaker is the imaging and IVUS-guided catheter for optimal left main and bifurcation stenting from Jung-Min Ahn from Korea.
Thank you, Chairman. I'm Jung-Min Ahn from Assam Medical Center. My topic is IVUS-guided criteria for optimal left main stenting. So how to optimize left main stenting? Previously, Dr. Gang published a very famous figure, the 5, 6, 7, 8. But these numbers came from the very heterogeneous left main stenting groups. And then these numbers again derived from the 9-month follow-up angiogram and instant restenosis rate. So in addition, other study groups presented the bigger number, the X-ray groups, and Spanish registry data suggested a more complex minimal stent area criteria. So based on our registry data, we divided into 2 stenting strategy, 2-stent technique and simple crossover technique. So we ignored only 2-stent technique by crush technique, mini crush, balloon crush, and conventional crush technique. We evaluated 3 point: proxy circumflex ostium, distal left main, 5 millimeters. We measured the minimum stent area. So distal left main minimum stent area cutoff value is around 12, but not associated with the long-term outcomes. The LAD ostium cutoff value is around 8.3. If the LAD ostium, the minimum stent area after the 2-stent technique, bigger than 8.3, very low event rate at 5 years. MACE is cardiac death, MI, target lesion revascularization is only 5%, but smaller than 8.3, 17.4. Circumflex ostium is the most important portion, the Achilles heels of 2-stent technique or simple crossover technique. So circumflex ostial minimal stent area is linearly associated with the hazard of MACE at 5 years. So smaller the circumflex ostial, the minimal stent area, the 5-year outcome is 17%, but the larger than 5.7, the minimal stent area, the 5-year event rate is only 6.6. So achieve the larger circumflex ostial minimal stent area, we can, I assume that we can overcome the Achilles heel of two-stent technique. When combine the each point, so if there was 2 under expansion at the circumflex or LAD, very bad outcomes, 20% event rate, but no under expansion or only single under expansion, 5-year event rate is very low, only 5%, 1% per year, very nice. So let's move to the simple crossover. We tested we can apply the MSA criteria, MSA concept to the simple crossover stenting. So we measured the proximal LAD, distal left main, proximal left main, very similar to the two-stent technique. Even simple crossover stenting, minimal stent area concept is very important. So proximal left main 11.4, very nicely separated under expansion and over optimal expansion. And distal left main 8.4, and LAD ostium 8.1, the bigger and smaller, nicely demonstrated. So 2-point under expansion associated with very bad outcomes, 5 years, even after simple crossover stenting, under expansion at the 2 segment, very high event rate, 24%, but one under expansion or low under expansion, after the simple crossover stenting, event rate is very low, annually 1 or 2%. So then, next question is how to decide the one stent or two stenting. We have 2 randomized trial, ABC trial, DK crush trial. One trial favored the simple crossover, the other trial favored the two-stent technique. So why? I think the evaluation is different and technique would be different. So many left main, some favor the simple crossover, the other favor the upfront two-stent technique. So far, we have only one general criteria to select one stent or two stent. This is a very angiographic definition criteria. Every component came from the coronary angiogram. So, but traditionally in our center, as a medical center, we always evaluated IVUS, so focused on the circumflex ostium by IVUS. Angiographically, looks significant the circumflex ostium, but the IVUS show that the upper panel tight, but lower panel, the circumflex ostium looks good. So we selected the upfront two-stent technique for upper panel and just the crossover in the lower panel. So we gathered the true left main bifurcation, angiographically true left main bifurcation, and we selected patient 141 patient with pre-stenting IVUS pullback from circumflex. So we evaluated the circumflex plaque burden and minimal lumen area. The median is 4.3 minimal lumen area, and so circumflex plaque burden was 55 after inpatient underwent simple crossover stenting. So this is distribution. So we evaluated the circumflex compromise. The circumflex compromise occurred in 17%. The 24 cases out of 151. So we evaluate ROC curve analysis to predict the best predictor of MLA and plaque burden. MLA around 3.7, plaque burden 58 was associated 57, and plaque burden is 3.8. Minimal lumen area 3.8. The plaque burden is 57. Was the best predict the circumflex compromise, acute compromise after simple crossover stenting. But the circumflex ostial angiographic diameter stenosis, bifurcation angle, circumflex lesion length was not associated with the instance of acute circumflex compromised. So we grouped the 3 groups as a high risk group, and if the circumflex ostium is larger, low plaque, then we consider it the low risk groups. So we compare the two-stent technique and one-stent crossover technique, low risk group and high risk group. So we can get, as we expected that the one-stent crossover group, minimal lumen area is larger than two-stent cross technique, and the plaque burden is smaller than two-stent groups. This is a major adverse cardiac event. One-stent high-risk circumflex ostium, small lumen, large plaque burden, red line, and two-stent. One-stent high-risk circumflex ostial lesion is blue line. And low risk is dot. So based on this graph, a patient fate, left-hand fate is already determined according to the disease burden. If disease burden is high, whatever one-stent or whatever two-stent, long-term outcome already determined. So if we do the better stenting, so two-stent, even though the two-stent high-risk circumflex ostium with underexpanded, the higher, numerically higher event rate than one-stent high-risk circumflex ostium. But if we do the optimal stenting, two-stent high-risk circumflex ostium without underexpansion, numerically lower rate of event rate compared with the one-stent high-risk circumflex ostium. So this is our conclusion slide. Look at the circumflex ostium to decide the simple crossover or two-stent technique. If there is a high-risk circumflex ostium, large plaque burden, small lumen, upfront two-stent technique should be considered and optimization. And circumflex ostium, the large lumen, small plaque burden, why not simple crossover stenting and optimization of each point? Thank you for your attention.
Okay, thank you, Professor Ahn. So now let's move on to the last speaker of this session, Professor Jung-Min Lee from Samsung Medical Center, and he's going to talk about the hybrid approaches with DCB. Please.
Thank you, Professor Gu. Hello, everyone. I'm J.M. Lee from Samsung Medical Center. My talk will be hybrid approach or DCB-only options in bifurcation PCI. And I borrowed this slide from Professor Gu's presentation. And previous two trials tested the standard approach for the side branch and most aggressive side branch treatment and the most conservative side branch treatment. So in smart strategy trial, they compared the conservative versus the most aggressive side branch PCI. So in this group, almost all patients underwent IVUS-guided stenting for the side branch with the very aggressive treatment criteria. And at 3 years, actually this strategy was worse than the conservative treatment. And DK-6 trial compared the standard approach and the FFR-guided selective side branch treatment. And in this trial, the FFR-guided group showed comparable clinical outcome with the angiographic approach. So a lesson from these trials, we can learn about for the unselected bifurcation region, side branch PCI does not influence patient prognosis, and sometimes it can be harmful for the patient safety. And from definition 2 and the EBC main trial, they compared the left main bifurcation PCI strategy. In definition 2, upfront 2 stenting was better. However, EBC main, it was comparable with the provisional approach. So the main difference between these two trials is complexity of side branch disease. So this left panel represents definition 2 type left main bifurcation with the very severe side branch disease, but the right panel EBC main type left main bifurcation disease with the relatively favorable anatomy in the circumflex. So when we compare the QCA analysis of these two trials, we can see the definition 2 trial enrolled longer side branch disease and more severe side branch stenosis. And the difference in clinical outcome in the definition 2 trial was mainly driven by lower risk of periprocedural MI in upfront 2 stenting techniques. So this means that in the presence of very severe side branch disease, upfront 2 stenting may be needed to prevent periprocedural MI. So these two trials gave us the lesson about for the complex bifurcation disease, side branch PCI may influence patient prognosis. However, it is very minor effect in terms of regarding the peri-procedural MI. And regardless of treatment strategy for the side branch, stenting, balloon, or DCB or something, the most frequent locus of TLR is always at the side branch. So in this bifurcation pooled cohort, in first generation, second generation, one stent or two stent, anyway, the side branch is the worst locus for the recurrence rate. Regarding the side branch treatment modality, the simple balloon versus DCB angioplasty, there was a very limited data. So in this meta-analysis with the study level, 10 studies, they evaluated the angiographic outcome, and as you can see, DCB was better than the simple balloon angioplasty in terms of angiographic result. And this single-arm study evaluated the safety of DCB angioplasty for the side branch, and it actually showed the side branch DCB had an excellent safety profile. Very recently, DCB bifurcation trial, they compared the treatment strategy for the jailed side branch disease. So in this trial, patients with true bifurcation disease underwent left main crossover stenting at proximal optimization technique, and with the jailed side branch disease, and after pre-dilatation, they randomized those patients into the non-compliant balloon angioplasty and the DCB angioplasty group. And at the 1 year, DCB group had a lower risk of MACE, which was a composite of cardiac death, target vessel MI, and the clinically driven TLR. And this lower risk of MACE was mainly driven by lower risk of spontaneous MI following DCB angioplasty group. So at current stage, this trial is the only evidence supporting the DCB angioplasty for the jailed side branch disease. So we can imagine that if we can apply upfront DCB angioplasty to the side branch in complex bifurcation disease, this strategy may be able to transform this complex bifurcation disease into the EBC main type bifurcation. So like in this conference, this upfront DCB angioplasty make it simple, more simpler bifurcation disease. And then we can able to go with the provisional approach if we can transform this type into this more simpler type bifurcation. So Korean Bifurcation Club is testing this hypothesis. So in patients with complex coronary bifurcation disease with the clinically relevant side branch, according to the definition 2 criteria, we are randomizing those patients into the standard upfront to stenting strategy or upfront DCB-based hybrid strategy. So in this group, the side branch disease is treated first with the DCB angioplasty, then stepwise provisional approach will be performed in this group. And the primary endpoint is this death MI and clinically driven target vessel revascularization. So let me show you one of the case example enrolled in this trial. This 63-year-old male avoided cardiac arrest. Actually, it happened in my hospital's the exercise room. So the cardiac surgeon applied AED at the time of the cardiac arrest, so successfully resuscitated. We did coronary angiography, total occlusion of LAD, and the very severe disease in the major side branch. So after pre-dilatation, we can see the true bifurcation with the clinically relevant diagonal disease. So these patients were randomized into the DCB-based hybrid approach group. So we applied the DCB angioplasty first, then crossover stenting, and the proximal optimization. Final IVUS showed excellent result. So what about DCB-only PCI in true bifurcation disease? There was no trial at all. However, we can see the subgroup analysis from these 4 representative trials. If you see the subgroup analysis, actually DCB angioplasty performance was better in the bifurcation disease than the non-bifurcation disease cohort. So, ladies and gentlemen, this is my summary. Side branch PCI generally does not influence patient prognosis except complex through bifurcation disease. So in side branch intervention, DCB was better than simple balloon angioplasty, and theoretically, upfront DCB angioplasty can transform definition 2-type bifurcation into the EBC main type bifurcation. So further RCT is needed to test this strategy will be relevant, and the very limited data is present for the DCB-only strategy in bifurcation disease. So maybe we need further trial to clarify this issue. Thank you.
Thank you, Dr. Lee, for the very excellent and clear presentation. So we have around 8 minutes, and all 6 talks are open for discussion. So any suggestions and comments will be welcome. Okay, so Professor Colombo?
I would like a comment regarding DCB for side branch. When we have a complex bifurcation, including the left main, our approach is contrary to the bifurcation club. We do dilatation of the side branch, kissing balloon, main branch and side branch, and then according to the decide, we make the decision if continue with provisional with the main branch and DCB on the side branch or do a different approach. So first we prepare the lesions, and then after lesion preparation we make the decision.
Okay, so thank you. Professor Colombo, as you are there, may I ask you one question? So you developed a crush technique to fully cover the side branch, and recently there are some people who are saying that the missing just 1 millimeter side branch osteo may be enough, so they try to move back to the T technique with the shouldering of some parts. So do you still believe that with the current generation DES, missing 1 millimeter or 0.5 millimeter is still a big matter to stenting?
I agree with you. I don't believe that missing 1 millimeter is a problem. I think the problem is more complex. And with the availability of drug-coated balloon, I believe we should minimize the use of 2 stents. And of course, there are some situations where unavoidable, but elective 2 stenting to me should be almost 0.
Thank you. So any further questions, comments?
I have one question for Dr. Jung-Min Ahn. I'm quite familiar with the own IVUS criteria from Assam Medical Center for a long time, 5, 6, 7, 8. But from your data now, do you recommendation to use the new IVUS criteria in routine practice for all patients?
Thank you very much. So I don't make you confused. So 5, 6, 7, 8 is enough, I think. But if we can do more, so the bigger lumen would be better than the smaller lumen. So this number is just a benchmark. So my message is make a good lumen. That is important, I think.
So simply speaking, the larger may be better.
Yeah.
But while listening to your talk, I'm a little bit confused about 0-1 to underexpansion comparison. So consistently show that the 0-1 is better or 0-1 no difference. That means that even if we miss some part, left main, LAD circumflex into stenting, would that be fine? How we can understand that contradictory messages from your papers?
Yeah. Also, that observation was makes me confused. But my understanding is that even the group is 1 under expansion, the under expanded stent lumen is not that small. So very similar, similar to the optimal criteria. So the 1 under expansion means that make effort to make a good opposition and good expansion. So such effort to make only 1 under expansion didn't affect the overall outcomes.
Thank you.
And I'm very interested in the IVUS criteria, Doctor. the IVUS criteria for discriminated one stent or two stent. The plaque burden, LCX plaque burden is less than 56% and less than plaque area, lumen area 3.8. Yeah. But however, sometimes such kind of moderate stenosis did not show the significant FFR value for the LCX. What kind of, how do you treat such kind of region?
So, thank you very much. So, my point is that, yeah, I fully agree with the 3B strategy. If we can rescue the circumflex, so one stent crossover is the best strategy. But based on my practice, after simple crossover stenting, rescue the JLD circumflex sometimes very difficult. So in such cases, I recommend you to do the simple upfront the two stent technique rather than simple crossover technique. Already, I show you the Kaplan-Meier curve. Already, left main fate already determined. The large plaque burden, worse outcome, small plaque burden, better outcome. Whatever one stent, whatever two stent technique. So my point is that during the procedure, we have to avoid the complication. So to empathize the simple crossover stenting, I believe that many operators lose the side branch. But yes, non-left main side branch, it doesn't matter. But the left main side branch sometimes make a patient collapse during the procedure. So my point is that don't afraid to do the two stent upfront the two stent technique if side circumflex ostium is very small and large plaque burden.
May I ask how many percentage of the IVUS criteria for the optimal for the approved two stent? How many percentage are the whole bifurcation cohort?
Yes, so our cohort circumflex compromised is 17% after the simple crosswalk stenting, but the side branch compromised mostly due to the angiographic tight stenosis. But the flow TIMI 0 or TIMI 1, TIMI 2 is only 2 patients out of 141. So side branch flow compromised is very rare even after the simple crosswalk stenting through bifurcation.
Yes, please.
I had a comment and then a question for Dr. Lee. So I guess we're kind of now moving away from one stent versus two stent because now we have one stent plus DCB, two DCB, two stent, or just a single stent. So I think, it's this session has kind of highlighted that there's a lot more approaches towards the bifurcation. And Dr. Lee, maybe a question for you. With regards to DCB in the side branch, there's now 2 trials looking at this. One was presented recently at TCT, and I don't think was included in your slides here. But really, what's the best approach to DCB the side branch? Do you do it before and then do a provisional like the EBC has recommended? Or do you do the provisional first, recross, kiss, apply the DCB, and then finish off that way?
Yeah, that's a wonderful question, and it depends on the possibility of losing side branch after provisional stenting. So, actually, in the SMART DCB trial, actually Professor Colombo exactly described the procedural step adopted in DCB-based hybrid approach group. So we usually did DCB first and kissing balloon, then look the angio if that is okay, then provisional approach. But sometimes side branch is expected to be perfectly okay after provisional stent. In that case, we adopt DCB angioplasty later after putting the main vessel stenting. Thank you. It depends on patient.
So the time is set. We're close. This session of the bifurcation PCI concept of technique, you can realize detailed concept and the technique. So thank you for attending this session. Thank you for attending this session.